All right. All right. Well, good morning, everybody. Welcome to the Training Wheels Off support group for women and women with Parkinson's and their care partners. We're blessed this morning to have with us, this afternoon, I should say, Dr. Atilio Palma. He's a Florida neurosurgeon, accomplished neurosurgeon who does the deep brain stimulation surgery. And I know most of us know what that is. Some of us in our group actually have had it done, some recently, some many, many years ago. But he's going to tell us a little bit about what, or a lot about, what DBS involves. And at the very end, we'll have open question and answers for those who want to ask Dr. Palma some questions. So with that, I'll turn it over to you, Dr. Palma.
Thank you. So first of all, I want to start off. This presentation kind of has Boston Scientific all over it. I use Boston Scientific. I also use Medtronic because I think both have their advantages, especially in terms of technology. But really, what I want to talk about is sort of some brief points on Parkinson's. Just a very brief overview of what Parkinson's disease is, and that's not necessarily something I have to tell all of you about because you all have experienced this firsthand. But we'll talk about some of the treatment options, and then what deep brain stimulation means, not just with Boston Scientific, but even with Medtronic, and most of the companies are fairly similar. Just a few nuances in how they do things, but the general portions are all the same. It just gets down to some programming things between each of the companies, and then some resources that Boston Scientific also has available. But again, this is just a very small surface overview of what the resources are. There are plenty of places like your organization, for example, that has a lot of personal one-on-one information for patients that I think are extremely important. And so Parkinson's affects about 1 million Americans, 10 million people worldwide, and so it's about 1% of people over the age of 55. It is unfortunately a progressive degenerative disorder. We really don't have a great answer for this medically, and by that I mean giving medications, because at some point you will phase out of being completely responsive to the medications. And we do know that there is a decrease in certain cells in the brain that produce dopamine, which is really the target agent here. So as dopamine goes down, then Parkinson's symptoms become more prevalent. And so, with that being said, we can basically split Parkinson's up into two different categories. And so the people who have motor symptoms are people who have things like rigidity or speech problems. Tremors are really a common issue. And so is a change in your gait. So people will get shuffling. They'll also get instability. So if I think one of the more difficult things for Parkinson's patients is, for example, once you start walking, trying to stop your movement is really hard. And then trying to make a turn can be very difficult. So falls can be very common. The other thing is people start to get slower. Their handwriting starts to change. And, simple things like eating with a fork or a spoon, eating peas is one of the things that people talk about the most. Is becomes a very difficult task. And so those are the motor symptoms. The non-motor symptoms become changes in your mood. You do start to get pain. There are some back issues, thoracic and lumbar spine issues that are associated with Parkinson's. You can have insomnia. Your sense of smell can change, and also even your level of activity can change because you just don't feel like doing things. And so, the first column in this is what I think is one of the most beneficial things that you can do in Parkinson's, and that's exercises. Down here in Naples, there's a group that does boxing classes for Parkinson's patients, and a lot of patients look at me like like I'm telling them something very foreign, and it seems so weird for me to tell them to do boxing classes. But actually, it really is helpful with balance. And so, that's not the only thing you can do, but there are multiple other exercises that I think can be really, really helpful to try and treat things like balance problems. Medications, obviously, the advantage to dopamine is huge. And when dopamine first came into the market, we kind of thought, well, this is the answer to it. This is how we're going to treat Parkinson's, get rid of Parkinson's, and then quickly realized, that people were actually sort of moving away from being responders of dopamine. So we started coming up with different agents to either extend the life of, carbidopa, or other agents to try and mitigate some of the symptoms that or the side effects that came from dopamine. And I think almost serendipitously, we came up with, pallidotomies and thalamotomies, which are ablative surgeries. And those came about because other problems have, people had a stroke that affected the thalamus and a certain part of the thalamus, and all of a sudden some of their Parkinson's symptoms got better or tremors got better. And so we started to think, okay, maybe that's a target in the brain that we could use to treat movement disorders. And so we sort of made the leap into deep brain stimulation. And I think that really took, a huge leap once the technology in cardiac stimulation got better. So pacemakers, once that technology improved, then deep brain stimulation improved it as well. And the other thing that we've realized is while you can you can give someone medications, you can put someone in line for an ablative surgery or a stimulation surgery. The reality is you really need to sort of encompass all this or cap it all off with some form of therapy. And it can't just be 6 weeks. It should be something that's ongoing. It's something that we really try to get patients to understand that they have to incorporate into their daily lives. Because, while the medications help, it's being active and staying active and trying to improve balance and all those things. It really, really makes a huge difference for people. And so, deep brain stimulation, you can see that essentially all the working parts of DBS on this screen. There are, what everyone calls the battery, and it's really, the pulse generator. I guess it's a fancier name for it. But the brains of the whole operation are, housed in this little tiny battery pack, if you will. And every company has, a non-rechargeable option or a rechargeable option. And obviously the non-rechargeable ones are usually bigger because, you have to have a device that holds, enough current for a long period of time. The rechargeables don't, because you have to recharge every few days. And so they can be much smaller, less noticeable on the skin. And then, the leads change. I think nowadays no one is getting implanted with leads that are not directional, meaning you can send current in a particular direction outside of the lead. Before, it used to just be a circle around each one of the lead contacts. Now we're a lot more eloquent in what we can do, so we can sort of aim that energy at a specific area much better than before. And so what I tell people is the things that I can target the most are the motor symptoms, not the non-motor stuff. And not all the motor symptoms, respond really well to DBS. So things like, head bobbing tremors or voice tremors, or if you have only imbalance, I think of those as trunk symptoms. If you think of a tree, the trunk is the stuff in the middle. Your arms and legs would be the limbs. So the stuff that really comes from the trunk, they're difficult to treat. So voice is a midline thing. It's a midline problem, really hard to treat with deep brain stimulation. So is head bobbing, very difficult to treat with deep brain stimulation. And those typically are more essential tremor problems. But instability or postural instability is very much an issue in Parkinson's disease. And that's a little bit more difficult to treat with deep brain stimulation. And so most everyone will stage surgeries so that the first surgery you have a lead implanted into the brain, and the what we call the proximal portion, or the part that goes into the brain, is tunneled out so that the distal portion is left somewhere in your scalp. And then for the second portion of the surgery, we put the pulse generator in the chest area, and then an extension set is connected between the proximal leader, the one that goes to the brain, and the battery pack. So what you see on the right side of the screen actually shows a complete system, but there is usually a connection between the battery and the proximal lead. And so one of the other issues, and I sort of touched on this with levodopa, is you have all these symptoms that can come on after you start levodopa. And so dyskinesia is the big thing. And one of the targets for DBS, or one of the goals for DBS, is to try and increase the on time. That means the time of improvement of your symptoms while you're not on the medication. So if you look at early Parkinson's disease, when you give levodopa at the very beginning, you see that there's this curve, and it's an elongated curve, and that's a time of symptom improvement. And so it corresponds with the half-life of medications. And so as you progress through Parkinson's disease, now you need more medication to get a lesser effect or improvement than you did before. And so you have these undulations and symptoms, and sometimes the side effects make this worse, because you can get dyskinesias that make, as you see in the advanced Parkinson's disease area, the dyskinesias can make the off time worse than what you had prior to being on medications. And so these fluctuations can really be life altering for people, because they cause some morbidity in them themselves. And so what we're really trying to improve is that on time, that optimal treatment time of medications with DBS. We're trying to bridge all that. And so the patients with mild symptoms, medications are usually the way to go. The patients who have some moderate symptoms but are advancing or having to increase their medications, then that's really the optimal time to think about DBS. Once you have gotten into severe symptoms of DBS, or Parkinson's, or disability from Parkinson's, it's really difficult to say, let's take all this surgical risk to maybe gain a small fraction of improvement in your symptoms, because at that point it may not be worthwhile. The risks may outweigh any of the benefits. And so things that would kind of push you out of candidacy would be dementia, any medical problems that might make surgery riskier, or if you're in very late stage Parkinson's disease, because we know we can't really help. So the ideal candidates, are people who have responded to dopamine in the first place. Because in my mind, if you didn't respond to dopamine, this is probably not typical Parkinson's, probably not going to respond as well. If your on and off fluctuations are starting to increase, and they're getting worse, that's the time to really think about it. If you're having dyskinesias, especially, that are pretty troublesome, that's a great time to think about, deep brain stimulation. And tremors are, I think, such a great response to tremor with DBS, that I think that if that's the predominant issue, then you really should consider DBS. So, because I think, most people think I should wait as long as possible to have DBS, because then I can take advantage of the effects later on in my disease process. And that's not true. You want to actually take advantage of it as soon as you possibly can, because then you can have a much better and more productive, retirement or life, because you're going to get so much more time of that on time with medication and DBS. And so, DBS can reduce approximately 70% of tremors. And in my clinical practice, I think it's probably a little bit better than that. I think 70% is really a conservative number. Um, and then for sure, DBS can give you a big increase in your on time during a day. So it helps you be more productive, get out to dinner with friends or just enjoy tea, coffee, even a regular dinner that might be difficult when you have, pretty severe tremors and dyskinesias. For some people, you can reduce medication, and that's always our goal, is trying to reduce, all the medications and Parkinson's we can. But, you know, I would never promise anyone that we could certainly take them off the medications, because that's never my goal. My goal is to increase the improvement time, on the medications. And then obviously, because we're improving tremors and dyskinesias, then, or rigidity, then we can certainly improve quality of life. Because, like I said, one of the big issues is eating things like peas, or, buttoning buttons, and simple tasks that most people don't think about in their day-to-day life become more and more difficult with Parkinson's. And those are the things that we really, really want to try to improve, so that your overall quality of life improves. And, some of the risks with deep brain stimulation, anytime I tell patients that I open up the skin, there's always the risk for infection and bleeding. So we are putting the leads very close to areas that control movements in the body. So things like speech are still affected in this area. The vision centers go very near, or the tracks for vision go very near where the leads go. And so sometimes we can also affect mood. And along with this, with the risk factor of bleeding, you could have a bleeding stroke at the tip of the stimulator or lead, or anywhere in the pathway of the lead. And, blood in the area can be a potentiator for seizures. Now, the risk of any of these things, happening are exceedingly low. If you look at, I think the national, if you look at studies nationally, it's probably less than 2 to 3%, but it's not zero. But certainly, I think in surgery overall, we've tried to work to get our risks of complications down pretty low. And so, you can see some of the devices, the programmer, the pulse generator, and the recharger. And then, we've done tons and tons of studies on this. I think DBS has been studied ad nauseum, and we have really realized that it is a safe procedure to do that has huge outcomes. And so, when you start on your DBS journey, I think one of the first things to do is really have a long discussion with your neurologist to see if they think that you're a candidate for it. Once they do, they'll usually send you to someone like myself. And then there are a few things that I send people for. One of them is a neuropsychological evaluation, just so that, we know that we're all on the same page once we start this journey. There are some imaging studies that we also get to make sure that, there isn't something that's going to make the surgery riskier, or some other issue that might be going on, like a previous stroke or some bleeding in the area, or something that's already happened that may make your symptoms worse. Once you get past all those things, then we go to lead implantation surgery. And one of the things that I do different that I think most other centers don't do is I don't use the typical frame that most everyone is using. So if you haven't seen pictures of DBS or videos of DBS surgery in the past, one of the things that is used as a clamp on your head, and it keeps your head really still so that we can get the lead in the precise area. So there is a newer device that actually clamps onto your skull, but does not keep your head in a rigid position. So, you're awake for a portion of this surgery. And I think that's one of the things that people found to be really taxing is to not be able to turn their head, not be able to find a more comfortable position because their head was, in a rigid fixation. And I think doing it with this different kind of frame I use, it's a frameless procedure basically, really has made a huge difference for my patients. And so, we'll do this awake, we'll put the lead down, we'll stimulate, and then once we find a good spot, then we close everything up, and then you come back for the second portion of the surgery, which is implantation of the pulse generator. And then once that's in, then you follow up with your neurologist, or certainly we can do it in my office to actually program the device. And so in Parkinson's, there are really two spots or targets that we go after. One of them is GPI, and the other one is STN. And you can see sort of this is a cut through the brain as if we were looking from someone's face, back. And so different symptoms will determine sort of where I prefer to go. And so, I navigate a lead precisely to these areas based on known target coordinates and based on your imaging findings. And so, after the leads are implanted, then, we'll get a CT scan after surgery, and that helps in programming the device afterwards so that we can have a fairly precise view of where your lead is in your brain, and then use that to change the programming parameters to better treat, your symptoms. And then, like I said before, there are really two options with the pulse generators. So on the left, you see the non-rechargeables, and again, those are a little bit bigger because they have to hold or charge for a much longer period of time, so essentially years, as opposed to the rechargeables, which don't hold a charge for that length of time because you're having to recharge those. And so the one good thing about the rechargeables is that the devices are much smaller, they're much easier to hide underneath the skin, so really they're fairly attractive in that sense. And then the battery life for the rechargeables, that means how long it can be implanted in your body, is about 15 years. So we'll start seeing changes in charge capacity and stuff at that point. And so at that point, you should think about changing it out. And all of them, really all the newer technology is MRI compatible. So this is another very common question that I get is, can I still have MRIs after I have DBS? And the answer is yes. The other common question is, what do I do at the airport when I go through TSA? And usually you'll get a little patient card that will, tell all the TSA folks that you've had deep brain stimulation. So, this is just sort of an example of what the recharging or the charging device looks like. And, this patient has had, a pulse generator placed in, and he just puts this little recharging device into the sleeve just over where the pulse generator is. And that's, how you can charge it. So you can essentially be out and about and charge your device without having to, sit by a wall outlet, charging yourself. And then, you'll get a little device that allows you to check your battery level. You can adjust some stimulation, and then you can turn it on and off, especially if you're having an MRI or after the MRI is done. And so Boston Scientific, provides quite a lot of resources. I know this group is a huge resource for all of you, but Boston Scientific also does have several resources that are, pretty easy to reach. And so, you can actually see what other patients' journeys have been like as they've gone through DBS surgery. And, here are some samples of some of the ambassadors for patients. You can sort of read what they've gone through. And here are some references for the talk today. I think at the very end of this, I missed it. There is a website that actually gives you some info that you can go to online. I think it's my DBS. It's dbsandme.com. And so you can go there and find all these resources. So thank you all very much for today.
Okay. Well, again, thank you very much, Dr. Palma, for coming and for giving us that presentation. I know that answered a few of my questions without even having to ask any of them. So that was pretty good. So we'll open it up for open Q&A. So if you have a question for Dr. Palma, just either physically raise your hand or use the raise hand feature in Zoom, and I will make sure we can get Dr. Palma to answer your question. Let me just scan around, make sure nobody's. Go ahead, Edie. I unmuted you.
Thanks. Thank you for that presentation. It was very informative. I appreciate it. My question is, I was diagnosed 11 years ago, and
Mhm.
I don't take levodopa, I take razagiline.
Mm-hmm.
If I get to a point where I want to consider DBS, would I be a candidate, or do I have to go through a period of time taking levodopa?
No, that's a great question, actually. So it's not just the dopamine agonist that you need to take. It's you have to respond to some kind of medication for
Okay.
Parkinson's disease. So, that's where if you haven't responded to any medication in the past, and sometimes, I'll see patients in this situation where they haven't responded to anything, and so the neurologists wonder if they might be candidates for DBS. And a lot of times, it's not that it's a hard no, but it's a lot more unpredictable. And so, if you've not responded to anything, it's hard for me to say yes, we'll improve your symptoms if we've not seen any response to any medication in the past.
I see. Thank you.
Mm-hmm.
That leads me to a question I had. I was reading an article. I shared this with Blake before. I was reading an article about adaptive DBS. Do you know what that means?
Yeah, so that's Medtronic's thing, right?
Oh, okay.
And and I use Medtronic. So it's a little bit of a misnomer, I think, at this point, because yes, there is some sensing capability from the pulse generator. So their generator can sense what brainwave activity is like around the lead, but it doesn't actually adapt the therapy based on what that is. There's a manual adaptation that has to be done. So your neurologist or whoever programs for you actually has to go in and manually change settings. So it makes it seem like, that there's this AI sort of feature to the device when it's really not quite there.
Hmm. Now you mentioned that the device, like the Boston Scientific, comes with a remote.
Mm-hmm.
Is there a way that you can communicate with the device with your phone and then send that information to your doctor electronically?
Yeah, so some of the devices do that. You can't send the information electronically, so you can communicate with your phone to the device. But none of them at this point have, the capability of sending, say, it's been sensing for the last 3 weeks, and I'm going to send this to my neurologist and see if they can improve my programming. Unfortunately, we're not there yet.
So you would have to physically go to the doctor. You'd have to download the data, analyze it, and then have you come back in and make some programming changes. Yeah.
Exactly. And that's why I say the adaptive is a little bit of a misnomer. It makes it sound like the device itself does all the programming and does the changing of the programming, but it actually does not. You still have to go to your neurologist. The neurologist has to sort of, weed through the data and say, okay, this contact is better, or perhaps we should go up on the energy being, given through a particular set of contacts to improve symptoms. So there's still quite a bit of human input that has to go into it.
Do you see are there any things that the DBS industry is working on in the way of breakthroughs that you see coming down the pipeline?
Yeah, I mean, I think both of these things, both having a way of tracking the lead to better improve programming through imaging and through brain sensing, I think those are things that are just going to leap the devices forward in a whole new way. Because, with this huge uprising in artificial intelligence is only going to make the things that you're asking about so much more improved for patients, in the future. So I think it's coming. It's slowly making its way into DBS.
Okay, yeah, that's good. That's a go ahead, Edie. No, let me call on Sue. Go ahead, Sue. I muted
Uh,
you.
Hi, doctor. Thank you. You might have addressed this and I might have missed it. You said the average battery lasts 15 years. So then
Mhm.
would you surgically go in and remove it from under the skin and replace it with another one?
Yes, and the non-rechargeable ones. So once they've exceeded their lifespan, so the non-rechargeables, it's hard to say how much of a lifespan those things have because it's all dependent on how much energy your brain requires, right? So for some people, it could be 5 years. For some people, it could be 3 years. For some people, it could be longer. So it's difficult to necessarily predict without having a battery in and knowing how much energy you're using, how long your battery life will be. But with all the devices, the rechargeable and non-rechargeable, once you've gotten to that battery life, yes, you have to go in and surgically remove the battery and replace it with a new one.
Okay, thank you.
Mhm.
Edie, did you have another question?
Yes. Is there any concern with microwave ovens? Do they affect the device?
Nope, they do not.
Okay.
That's a good question. I hadn't thought of that.
Yeah.
Heating your leftovers might be a problem. Chris Romanek, go ahead. I unmuted you.
So you talked about the benefit for tremor. Can you talk about what success rate you've had with either rigidity and or bradykinesia?
Yeah, so actually, I had a patient recently who had rigidity that was pretty bad, and it was almost a dystonia, really, of his foot. Um, and we were really going after his dyskinesias, but the rigidity, we saw like a 90% improvement in actually his a dystonic sort of foot. And so the rigidity, I would tell people we could still get a fairly good response to. But the things that I think are the chip shots, the low hanging fruit in this are the tremors and the dyskinesias. Those are the really, really easy things to target with this.
Did that answer?
Any feedback about bradykinesia?
Yeah, I think bradykinesia can improve some, but it's not the predominant thing I go after because it's just a little bit more difficult to get, you know, say 70 or 80% on. I haven't seen a huge improvement in bradykinesia. There's some, but it's not like you get with tremor and dyskinesias.
Thank you.
Mhm.
Marie, did you have a question?
I do. I have two actually. I read that it can improve sleep, pain, and urinary problems. What's your experience with that?
You know, so pain, the only way it can improve it really is if you treat things, if you improve like dystonias, right? Or rigidity. That's where it can treat pain. So it's not targeting necessarily pain itself. You're going around, but you're treating the issue that's causing the pain. Sleep, I also would not say, if you came to me and said, I have Parkinson's, my predominant symptom is lack of sleep, then that's not a reason for me to say, let's implant a DBS. I think if it comes as a package with some of your other symptoms, we can certainly improve some of those. But, if that's the predominant symptom, then, I would not expect DBS to make you better.
Gotcha.
Did that answer
Okay.
both your questions? Go ahead, Marie.
Sorry, I was going to ask my second question.
Sure.
And when you talk about the risk, speech impairment, eye vision, can you kind of say
Yeah.
percentage wise how often that happens?
Yeah. And so vision, it's not like you're going to lose all of your vision, right? It's just that we can stimulate around some of the fibers or the pathways for vision. So it can almost distort your vision or cause little flickering lights in your vision. Okay. And the speech stuff, there can be some cessation of speech, but in that if you stimulate, speech gets slower or diminishes in volume. But really, you look at all that stuff in the surgery anyways. That's why you stimulate in the procedure, because you want to make sure that those things are not happening. So ideally, when you get implanted, you will have worked all those things out. If you're too close to the vision centers, then in the operating room, you will see those flicker of lights. And sometimes we increase the intensity of electricity that's going through the lead so that we intentionally look for those symptoms, so we know we're close and we know we're in the right spot. But really, you know, if you're going to get those symptoms, you're going to see those in the operating room, and so you just change, the placement of the lead. So really, the risk of you having vision problems afterwards or speech issues that are significant afterwards are pretty small, because you're going to look at all that stuff in the OR anyways.
Okay,
But
great.
that's a
Thank
great
you.
question. Mm-hmm.
Yeah, that question about sleep made me think about myself particularly. I have REM sleep disorder, so I act out my dreams. That's why we have two body pillows between me and my wife, because before I got diagnosed with Parkinson, I didn't know what I was doing. I was just kicking out and punching out. Does the DBS give you any improvement as far as RBD?
Sometimes, but again, if that's the predominant symptom, it's not the thing that I would, place a DBS lead for.
Okay. Okay. Thanks. Anybody else have a question or for Dr. Palmer while we're all here? Usually, go ahead, Edie. I unmuted you.
Just was curious, is this something that's covered by Medicare?
It is.
Good
That's a very common question, actually. And it is covered by Medicare.
Excellent. That's a great question. Thanks, Edie. Go ahead, Sue.
Because of exercise being so important for people with Parkinson's, what's the recovery time after surgery? I mean, you're having your brain surgery, so do you have?
Yeah, that's a great question. So the way that I explain this to patients in my office is, the first surgery, I make a small little window into your skull. It's about the size of a nickel. And then, the thing I really keep people from doing right after surgery is taking a flight somewhere, because there is a little bit of air that's introduced into the cranial cavity. And so if you go up high elevation, then there can be more shift of air into the cranial cavity, because now there's a small opening there. So we really want to heal up from that. So that's really the thing I limit people from the most, is taking flights. Or obviously scuba diving would be another problem, because now you're going too low. And so that's the one thing I limit people from. But your normal exercise activities, I would really say once, you will get a slight headache after surgery for about a day or so. But once that subsides, I'm fine with you continuing your normal activity. After placement of the generator, which is the second surgery, the one thing I tell people is for, 4 weeks or so, I want you to not do tennis, pickleball, anything where you're having to move your head back and forth, a lot. Because we do want some scar formation around the lead, and there's some redundancy in it, so it's not usually a problem. But, why test the limits for the first 4 weeks or so? And so after that, it's fine to get back to normal activity.
Okay. But no climbing Mount Everest.
Right.
All right. Mark Spivak, you had a question for Dr. Palma?
I have a statement to make.
Sure, go ahead.
I'm one of the few that had DBS. I had mine back in 2010. For me, it was a lifesaver. I still have problems with my gait and my balance, but those are the things that aren't affected by the DBS surgery.
Yeah.
I tend to speak softly and quickly, as you can tell. Also not affected by the DBS surgery. But if I didn't have it, I would have been dead by now, I'm sure.
Yeah, and I hear that exact thing all the time. The DBS surgery changes people's lives in such a positive way, and it is a scary thing to think about. You're having a device implanted into your brain, and you think, oh my gosh, I'm going to be awake for a portion of this, and it's just really a scary thing. But I'll tell you, 9 out of 10 patients tell me this isn't really as bad as I thought it was going to be, you know, because especially with me, you're awake only for the important things, only the things that we need you to be awake for, the testing. All the other stuff, the stuff that would hurt with needles and all this stuff, you're not awake for any of that. You're asleep for it. And so it turns out to be, patients perceive it to only be like, you know, a 30-minute procedure because they're asleep for the other 30 to 45 minutes of it. And so they all realize it's not as bad as, you know, as it seems, but it is, you know, life changing. So it's a small period of time that can really make a huge difference in your overall functioning in your life. So that's a very common sentiment that Mark shared.
Programmer
Thanks, Mark.
also has a lot to do with it. Skill of the programmer.
Yes.
Yeah, for sure. That's huge. You know, getting the device in, that's the easy part. But programming afterwards and continuing the programming long term is really the key to making this successful.
I haven't touched my program in at least 10 years.
Wow. Thanks for sharing your experience, Mark. It does make me lead me to a question, which I realize I'm probably asking you. You're not necessarily prepared for, but in your experience, how does focused ultrasound compare to DBS? Because now I've heard that in the past you couldn't do DBS after focused ultrasound. Now you can. What's been your experience with focused ultrasound?
So, and I apologize, my battery will die soon. But so the one thing, I've had several focused ultrasound patients come to me because they do get, unfortunately, a different kind of tremor after a focused ultrasound, so a Holmes tremor, which is really difficult to treat with deep brain stimulation. And if you look at the literature, you know, really, in reality, we can control about 90% of a tremor with DBS. You know, that's not unheard of. Holmes tremor, it's like a 50-50 chance of improving symptoms with DBS. So it's really, really hard to try and improve symptoms after the focused ultrasound, because what it does is essentially burn a small little hole, you know, into one of those two targets we talked about. And so, you know, I think it's great if you don't want to go through a formal surgery, but it still is a procedure. And, you know, I tell people it's like you're going to get baked like a cake. You go in for 30 minutes and then they ablate and then they pull you out. They look for symptoms. They put you back in and then they pull you back out and put you back in. So it's a process in and of itself too. So
that's good to know. And I didn't know that that if you had that done, it could potentially cause a tremor that wouldn't be that treatable by DBS.
Yes. Yeah, I've had several patients come to me trying to find a solution for a Holmes tremor, and the literature is not that compelling.
I had never heard of that before, the Holmes tremor. Thank you for sharing that.
Mm-hmm.
Chris, go ahead, Chris.
So I wanted to follow up with that about the Holmes tremor after the FUS. How long after the FUS would that Holmes tremor normally appear?
Pretty quickly. I mean,
I'm just going to give data that I'm on a call with some other people, and 3 of the guys on that have had FUS and not all to treat tremor. None of them did have the tremor afterwards.
No, and it's not that common. You know, it's not a common side effect of it, but it does happen, and then it is difficult to treat with DBS.
Okay.
Good to know, though. I never heard that before, so it's helpful information. All right. Anybody else?
I had a question. I heard that 9 out of 10 DBS patients are happy. Is there a common pattern in the ones who are not happy, or is
Actually, so 9
Good
out of
question.
10 patients tell me that it's easy, that the surgery was easy. I have to say, of all the patients, because I still do some spine surgery, I still do, you know, brain surgery other than this, and so universally, my deep brain stimulation patients are always happy. You know, it's just such a life-saving therapy. And it's a small price to pay for a huge gain in your function. So I do have to say that this is probably the thing that makes the most difference in people's lives.
Oh, okay. And in New York City area, are any of the companies other than the neurologists who tell you whether you are needed for DBS or not? The reason I'm asking is
Mm.
I was diagnosed 3 years ago, 4
Mhm.
years ago, and my condition is not as bad yet. But I had a
Yeah.
friend and she was diagnosed the same time, and hers has precipitated much worse.
Yeah, and that's a great time. I mean, now is the time to really talk to a surgeon, a neurosurgeon that is going to potentially do that for you, because they're ultimately going to make the decision as to whether you're a candidate for it or not. I mean, the neurologists are sort of the first check. The neurologist will suggest it and send you to somebody, but ultimately you want to see a surgeon because they will determine your candidacy.
Oh, okay. I assume neurologists are the surgeons also, so that's not the case.
Yeah,
Okay.
usually there's communication between the neurologist and the neurosurgeon to make that
Okay.
determination.
So I should ask her to talk to her neurologist to
Exactly.
recommend a
So they send her to a neurosurgeon so that they can talk about DBS and her candidacy for
Got it.
DBS.
Okay. Thank you.
Yep. Mhm.
Great question, Pradeep. Yeah, one of the things that I tell new people to the group, which I learned very early on, is that there's no one size fits all in Parkinson's. It's
No.
well said. If you met one person with Parkinson's, you met one person with Parkinson's, because everybody's on their own
Right.
journey.
Yeah.
You know.
Very true.
So, go ahead, Edie. You have another question?
Full of questions. You spoke about the window and for qualifying for DBS, and having the moderate symptoms. Is there also an age cutoff based on age, or is it based solely on your physical condition?
That's a good question. So, for me, age isn't a huge issue. I live in Naples, and Naples has the majority of people in Naples are older, very active. So, I I did it on a 91-year-old who is, I mean, acts
Wow.
and looks and, as if he was 70 years old.
Hmm.
He fooled me. I thought he was younger than that. So for me, there's not as much of an age cutoff. It's more of are you a safe surgical candidate cutoff? That's really what determines it for me. If you're on blood thinners and really cannot be off the blood thinners for some reason, then you're not a surgical candidate. If you have heart failure or other major issues, lung issues that would prevent us from doing an awake surgery, then you're not really going to be a candidate. And at that point, it doesn't matter if you're 50 or if you're 90, those things really make surgery much riskier. So for me, as long as you're a high functioning, adult without any major medical problems, then you're a candidate.
Thank you.
Excellent. All right. Let me see if I missed anybody. Oh, go ahead, Chris Rudolph. You're unmuted.
ESP. That make it good.
Say that a little louder next time. Go ahead. Okay. Sorry about that. Yeah, Chris was just diagnosed with PSP, actually.
Okay.
Did they do DBS for PSP, by the way? Just a question.
No, it doesn't really respond as well.
Okay. Just figured I'd ask. How about MSA?
Nope, I don't do it for that either.
Okay, so it's strictly Parkinson's.
Yeah,
Okay.
I do it for essential tremor too.
Central tremor.
Mhm.
Yep. Okay.
There are
Anybody?
a few other indications, but those are not two other
Okay.
indications.
Go ahead, Sue.
I was asking on behalf of someone else who's not here.
Mhm.
They have a tremor like in their jaw. Like, is that something that, because you say DBS can help with tremors, but
Yeah,
like weird parts of the body that it's not your arm, your leg. It's like,
right. And those are those trunk symptoms that are really difficult to treat. So head bobbing tremors, voice tremors, mouth tremors, those are really difficult to treat with DBS. The literature really doesn't give a lot of, you know, strength to the argument of trying to treat those. You have to treat both sides. And for most patients, basically, if you get to treat that tremor, if you get to improve it, then you're lucky. they're really, really difficult to target.
So
Okay,
it's more
thank
like
you.
more like
Mhm.
tremors in the limbs.
Right. The limbs are very, very easy, but not anything in the trunk. Anything in the middle is really hard to treat.
Okay. Did I see your hand, Thayer?
You did. I want to thank you for your presentation. I also want you to say hello to Dr. Michael Novak for us.
Oh, yes, I
My
will.
husband was a patient of his, Charles Caskey,
Okay.
who we moved last summer or last spring to Washington, D.C.
Oh, nice.
And
Okay.
so and while we were in Florida, we didn't get connected to this wonderful support group, but we did get connected when we moved
Yeah.
here because of
What a small world.
another person who's actually on this group. So anyway, thank you very much for your presentation, and you guys are doing great work down there.
Well, thank you very much. I will definitely say
Thayer.
hello to him for you.
Okay.
Thank you. All right. I think that's everybody's questions. So again, thank you, Dr. Palma, for coming and giving us the presentation. And I'll send out a link in the following email this afternoon with all information that Dr. Palmer shared with us. And this recording will be available hopefully within the next week.